All right. So here we are back again, boys and girls. Dr. Nikita Vizniak with the amazing
Dr. Catherine Chung.
And I weigh, actually no, sorry, pardon me. I am 180 centimeters or 6 feet tall, believe it or not.
Yep, and I am 5 feet tall, which is 150 centimeters.
And we are going to show you guys some variations in height and how you might set up biomechanically across different patients.
Exactly.
So to start with, why don't we go ahead and we're going to work on a PI ilium. So what's happened is the ilium is rocked back a little bit. We know that's fairly common, usually associated with a nutated sacrum. So we'll start off with that basic adjustment right there. So if I can, I'll have my patient lay down on her left-hand side, facing the wall this way. So a couple of key things here for us to realize. First of all, for a PI ilium, basic side posture setup, you still want to follow your basic protocol. So number one, I put my leg on the side of the table here, bend her foot up so it's back into her popliteal fossa, take her hips, and I'm pushing on the low side of her hips, and I'm on the inside of her knee, and I'm going to lift her up and slide her in like that. The next thing you're going to do is try to avoid pulling the shoulder out. If I pulled her shoulder out like this, I'd be putting a lot more torque in the lumbar spine. Generally, I'll have the patient up just a little bit like this and her head in a roughly neutral position like that. So this is our starting position for most side posture setups that we're going to be using. Simple, effective, easy to use. Next thing is finding the PSISs. Easiest way that I know to find the PSIS is to put my thumb on an iliac crest and your fingers will automatically fall to where the PSIS is. Mark the PSIS with your finger, sliding under to going to a hypothenar contact. Your tissue pull is going to be M to L, P to A, and I to S when we're doing this. But it's light right here. Where I see a common error for a lot of students is they try and get this right at the very start. Their shoulder sticks out. I've seen a number of practitioners actually end their careers with anterior rotator cuff tears from trying to thrust in this type of a position right here. So I want to be generally, and that's why we're wearing the tie right here especially, sternum over top of contact. If I can maintain that, I'm in good body position. So Catherine's going to take a big breath in for us. No pressure, she breathes out. I'm loading, 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 and full body drop into it at the end. Key thing for this one, we'll demonstrate it from the opposite side, is that my force is actually really being generated from my legs. What happens for a lot of guys especially, or a lot of people with a lot of upper body strength, is they try and jam through this with just their upper body, and if you do that, you lose about 50% of your power. The strength actually comes from your hips and leg moving back and forth, okay? All right, so same thing, we'll get her a little bit closer to the edge, over to the side like this. Nice neutral spine, so we know we're staying specific for the SI joint. Big breath in, and she breathes out, load, 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 hips and everything driving forward like that. How do I know this wasn't a lumbar adjustment? As I rolled her forward, I let her whole body come forward. I keep her stable so she's not going to fall, but I'm not giving her that real torquing motion across the body like that. Okay? So we'll have Catherine give a demo on this as a smaller practitioner.
So because I'm only, 150 centimeters we calculated?
Yep.
The side setup is going to be exactly the same because that's just how the vector is going to be. So the biggest change that you're going to be doing when you're setting up your patient is one, Dr. Nick was saying that he contacts the lower part of the hip and then the inner knee and then he'll lift the patient, but because I'm so small and that's just not something that I can actually do, what I tend to tell my patients is, hey, can you just move your hips in with my hands, and then I'll guide them and then they'll move for them, so then I don't injure my back and then they know what they're doing as well.
Yeah, great tip.
Just get you move forward. Excellent. So everything's quite stacked there. And then the setup is still going to be the same leg-wise, it's just how high you're going to get up. So because I'm so short, I have to really get up. Like I'm on my tippy toes here, which I'll show you on the other side of how high I really have to be, where my kneecap is actually into the popliteal fold here as well. And that's how I'm going to control his leg and his hips at the end of the day for all my side setups. So I'm just going to find his PSIS, and men's hips always throw me off because their iliums are always higher than their actual belt line, which is funny enough. So Dr. Nick's belt line is here. The top of the ilium is actually here, which makes his PSIS here, and the pant line always throws me off. I don't know why.
Yep, it's just, it's there.
It is what it is.
Yep.
So setup is going to be the same, a light setup like this, and then he's going to take a breath in, and then I set up my legs and he's out. Good, 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 and then all the way through like that. I would roll him a little bit more just so that I'm a little bit on top of my hand a little bit more. And then the drop is sternum over contact, and then I touch the sternum with my hand here, like that. or I touch my sternum to my hand.
Yeah, exactly. And that's a good point right there too, because you're able to deliver all of your body force directly into your hand when you do that.
Exactly. And the best thing is to roll them towards you. Instead of you bringing your body to their hip, bring their hip towards you, and then that will give you a nice mechanical advantage to actually have that crisp thrust through.
Yep, totally. Demo on the other side here really quick.
So setup is still the same. We're going to move forward.
That was a really good tip about saving your own back as the practitioner. Just guide the patient. You don't have to actually physically move them.
Exactly.
Yeah.
So hand contact over here is a stabilizer, and then on the Psis here. So when I said I'm getting, I have to come up high, like I'm actually on my tippy toes. Like this is how far I have to get up. So then as I'm coming down, then I bend my knee to really lock them out here. And then that's where the thrust is going to come. So can I thrust here?
Absolutely.
Okay, breath in and out.
Nice. Yep.
And then that's a moneymaker right there.
Yeah, exactly. Okay. A lot of patients, tight SI joints that are overlooked by a lot of other practitioners, so please make sure you pay attention to that. Mm-hmm. Okay, while I'm down here, why don't we go ahead and do a nutated sacrum, which would be the opposite, well, the same adjustment, really on the opposite side, right?
Exactly. So a nutated sacrum is when the sacrum has gone anterior and inferior, so it's kind of rocked forward.
And just to be clear on that, that's the most common variation of your spine. Like, what does the spine want to do? Every day you have gravity pushing down and your sacrum wants to nutate, and you get more of a hyperlordosis with that, so it's a common variation to see.
Yeah, exactly. So then with a nutated sacrum like this, because the base of the sacrum has gone forward and inferior, what our setup and our hand contact is going to be is on the apex of the sacrum, and then you just want to literally bring it back from the position in which it's going. So then you're going to be touching doing a superior to inferior tissue pull onto the apex, and then you're going to thrust posterior and inferior, I suppose. So it's like completely opposite of how the sacrum is sitting. The setup is exactly the same. And because you want to bring it backwards, that's where the hip. So if it's forward like this, and you want to be touching or contacting the apex, then the direction of the force is going to go in a clockwise direction. So if you follow that direction, then that means that the knees or the legs have to be greater than 90 degrees.
And that's huge. For this setup, for the PI ilium, you were less than 90 degrees. For the nutated sacrum, you're greater than 90 degrees to give you that biomechanical advantage to pull.
Exactly. So that means that when you're adjusting, it's going to go in this direction. So you have to move the hip in that direction. You can even see just from Dr. Nick's pants or even his shirt here where that force is going to go to just from me moving my legs. And this is why the leg movement and the hip movement is so important in these setups.
Yeah.
So then the tissue pull is going to be a superior to inferior onto the apex. So you're just going to find where the lumbar spine is, and then you can follow it down. Don't go too far down to where you're going to go onto the coccyx, because that's going to be quite painful if you actually adjust onto the coccyx. You can actually fracture or dislocate that coccyx if you put enough thrust into it. So it's just going to be on the sacral apex, which is going to be right here, Dr. Nick. And then we're going to do a superior to inferior tissue pull. And then the legs for me are going to be exactly the same. I'm going to get super high. And because I have to get so much higher, I always have to end up setting my legs up first before I set up my hands, because if I set up my hands, then it's going to be really awkward, like in this position. So to make it as smooth as possible, I set up the legs first, and then the hands. And then I'll get you to take a breath in, and out.
Yep, nice force. And you can see the other thing that she did too is you have to roll the patient over just a little bit more to get over top of that sacrum, right? So, yeah. All right, so I'll just do a quick demo of it as well. So, a couple of things. Everything here is exactly the same as she did. So I'm going to have the patient lay on the side, bring them up, flex the knee past 90 degrees, can generally bring the person out a little bit more. All of this is going to be set up in a relatively neutral position. Okay, so I say this as a joke, but it's 100% right. So her PSIS is right about there. What I see for a lot of students and practitioners when they set this up, they set up too high on the sacrum. Mm-hmm. They're somewhere like right around mid-sacrum like this when they thrust. I want to be right over top of the sacrum where it starts to drop down. But like you said, not over top. Like you said, not over top of the coccyx, okay? So her sacrum starts to drop, and what I need to do is kick forward with my legs. Now, because I'm taller, I don't have to get up on top of her to do this. I can stay a little bit lower and drive a little bit more with my hips forward, but the key principle is still exactly the same as she demoed. We're going to tissue pull S to I, pulling down, and bring her forward like this, where you can feel that's the load into her sacrum right there. Most of that force comes from my hips moving forward and me pushing down over top of her sacrum. We'll demo the same thing on the opposite side. So again, this is a setup for a nutated sacrum, bringing her a little bit closer to the edge, finding ourselves all the way down. And the key thing for us to get from this viewpoint is when I'm set up, I get over top of her sacrum. Oh, and that shifted right there, but all right. But you can see that I'm driving forward with my hips as I have my sternum over top of the contact. Easier for a taller person to do that. Okay? Anything else you want to add?
No, that's pretty good.
Okay. All right, for both of us, we got to tell both of us to slow down a little bit though. We're like, because that's the way we think, right? Yeah, I know, right? Okay. All right, so now we're going to go ahead and look at an AS ilium. So what is an AS ilium? The ilium has gone anterior, the PSIS, pardon me, has gone anterior superior. So I want to take that ilium and move it back. So, Dr. Catherine, if I can have you lay on this side facing me. She's going to be set up. This setup is exactly the same as a nutated sacrum, except you change your hand contact. All right? So to begin with, we're just going to bring her forward just a little bit more. My contact is going to be over top of the ischial tuberosity, and I call this more of a J-hook motion where you're pulling down and you're going to follow the line of the femur as your main force vector, actually, when we set it up. Again, to make sure this is SI specific and not into the lumbar spine, I'm not going to give a large counter rotation force. I'm going to stay relatively neutral. You're going to come over top of the ischial tuberosity and bring the patient around over into about this position right here. Again, whenever I can, sternum over top of contact so I can go ahead and thrust into that. Okay? And we'll get Catherine to go ahead and demonstrate this for us really quick.
Okay. So, like Dr. Nick was saying, same setup as usual. As any other side setup, I'll just get you to move your hips forward for me.
Okay.
Because I'm not into jiu-jitsu or CrossFit in any way, my upper body is actually pretty weak relative to Dr. Nick or anyone that has a higher or is stronger top body.
She's teasing, she's strong. Okay.
So what I like to do is use my forearm instead of hooking onto the ischial tuberosity with my hand. And that gives me just a little bit more of a compact position, so then I know that I'm stronger in a smaller compact position rather than in this bigger position or a more wider position for me. And instead of contacting the arm or the elbow here, what I like to do is hook onto the ASIS, doing a inferior to superior hook onto the ASIS there.
And I'll just make a comment on that. So she's got two advantages right there. Number one, she's using a shorter lever by using her forearm over top. She's going to have better advantage there. And number two, she has a second point of contact to really turn that ilium around if you want, right?
Exactly. And then I'm, like with all the other setups, I'm preventing him from rolling over using my legs and the rest of my body instead of stabilizing using my hand here. So again, hooking into the ASIS using an I to S tissue pull, and then onto the ischial tube, I'm just doing an S to I. So they're all in opposite directions. So essentially, I'm driving the steering wheel, if you will, in a clockwise fashion. And then the leg setup is going to be the same, so I have to set up my legs first, only because I have to get much higher. And then he takes a breath in and out, and then we would and then drop through.
Yeah.
Just like that.
Nice. Good power. Okay.